Hi, I'm Mesha Rodok and I'm a breast cancer survivor. I was diagnosed back in 2021. I, at the time, found a lump in my left breast, and it was a little scary at the time because it was different. You know, I was pretty in tune with my body, thankfully. So I would have done my self-checks, looked in the mirror, touch, feel, and something did definitely feel different. So I was encouraged to go and check it out.
So I went and I did this needle biopsy, not thinking anything of it. Then I get a call from his nurse again saying, Dr. Straits wants to see you. And I said, what for? She says, the results of the biopsy have come in and he wants to see you, and he wants to see you urgently. Okay. So all this time I haven't told my husband I'm doing any of these things, you know, because I knew there was nothing wrong with me. So I went in to see him, sat down, and he said, the results of the biopsy have come in and it has indicated cancer.
Hello and welcome to Pink Table Talk. It's a discussion about breast cancer awareness, and we just saw videos from two amazing women who are breast cancer survivors who will tell us more of their story later down in the show. For the next 90 minutes, we will introduce you to some of the top names in the medical field who will discuss various aspects of detection, treatment, recovery, and of course, support. We're also encouraging you to send us your questions via the Television Jamaica Instagram. Use the hashtag PinkTableTalkTVJ so that we can find you. Breast cancer is among the most common cancers globally. As a matter of fact, in 2022, there were an estimated 1,327 new cases reported in Jamaica, with an estimated 684 breast cancer-related deaths. So joining me now is the Chief Medical Officer for Jamaica, Dr. Jacqueline Besesa Mackenzie, and she's going to help us put this in perspective for our little island. Welcome, Dr. Besesa Mackenzie.
Thank you so much.
We have some statistics that we've been hearing and mentioning, but can you tell us what the updated numbers are for Jamaica?
Okay, so the numbers that we use and that are reported are from the WHO Global Can report. So these are world estimates that are done. We should be seeing an improvement in terms of our ability to provide more up-to-date statistics, because the Ministry of Health and Wellness has introduced a cancer registry last year. So now it is that persons right across the country are required to update the registry every time a new case is diagnosed. So very shortly we should be able to give more updated figures, but right now we're using the WHO estimates.
Which are? Which
is from 2022, which is, as you had reported, with 1,327 new cases in 2022 and just over 680 something deaths in 2022. And the important thing to note is that compared to 2018, that this has increased, because we were at about 900 and odd new cases in 2018, and by 2022 we are up to 1,300. And then in terms of deaths, we were at 400 and odd in 2018, and then we would have gone up to 684 in 2022.
That is scary.
Yes.
So what are we as a country putting in place for women?
Right. I think the most important thing, we have to start from the very beginning. And if health education is probably the most important for persons to realize that what these numbers are and that they are in fact at risk. Most people in Jamaica, most women will know someone either in their family or close to them that would have suffered from breast cancer. And so therefore it's very important that we understand that we are at risk. And our risk comes not just from the fact that we may have a genetic tendency, or a mother may have had cancer, there may be a familial history, and so therefore we are cautious and tend to test more. But also we have to realize that there are certain risk factors that put us more at risk. things like overweight and obesity. It's associated with a higher number of breast cancers. Alcohol use, tobacco use are also associated. And so we have to start from there in terms of education. And this begins really in our primary care centers, both in the public sector and the private sector, where it is that the physicians, every contact with every woman, whatever their life stage, should be informing them about their risk, what it is that they're at risk for, and what it is that they should start screening for.
So the education, I'm hearing about the education and how important that is. What is the ministry doing to actually encourage us to get tested? Because that's another step.
Sure. So in terms of testing, so we have rolled out our screening guidelines right across the country. We have been updating our doctors, educating in all different forums for persons to be aware of what the screening guidelines are. And for breast cancer, women are to start screening at the age of 40. If it is, of course, that they have a familial history or any other predisposition, then they would start before. And so in your discussion with your healthcare provider, those things may be highlighted and you may be asked to start screening from before. So we are trying to make screening more accessible. But remember that just as one of your the reports that you had earlier spoke about self-examination, breast self-examination, that is very important. And still, when we did our 2017 Jamaica Health and Lifestyle Survey, when we asked women if they had done the breast self-examination, only 28% of women would have reported that they had done a breast self-examination in the year before. So it's very important that we start with doing the breast self-examination that anybody can do. You can speak to your healthcare worker how it is that this should be done, and you try to do it at least once monthly, probably after the period, because usually before the period you may have some increased lumpiness in the breast, so it may be confusing. But you choose a time that you do it, discuss with your healthcare provider, and as the person before had said also, that she was in touch with her body, so you pick up the changes that occur, and therefore that you can bring it to the attention of the healthcare provider.
Maybe we need to start thinking of or self-examination as the test, or maybe the first test.
The first test.
And then the screening now is with the doctor as another phase of testing.
Certainly. So the education first, the breast self-examination, and then of course the starting to do the screening in terms of the radiological test, which is a mammogram, and sometimes the doctor will request an ultrasound as well.
If it is that unfortunately we come back and we do have a lump and it's cancer, what are our options for treatment here in Jamaica?
So treatment are along different lines. We have surgical treatment, and we have treatment with medication, chemotherapy. We also have radiotherapy that can be offered, and then of course there's palliative treatment. So the oncologist would be able to give you more details, but there are different modalities of treatment, and all of these are offered in Jamaica to some degree. Okay, so certainly in terms of when you first discover the lump, you may need to have a biopsy done, where it is that you may have a needle inserted to remove some tissue for that to be tested, or the entire lump may be removed for it to be tested. Once it is determined that there are in fact cancer cells, then it may become necessary for you to do a more extensive surgery, and that surgery may be minimal based on what the recommendation of between your oncologist and your surgeon, or it may need more extensive surgery in terms of having the entire breast and associated tissues removed. So after the surgery, then usually, if it is that the reports come back from the lab to show how extensive, how far it has spread, whether it was just contained within the tissue that was removed, or whether there was extension beyond the margins of the tissue that was tested, then you may need more treatment.
What I'm hearing though is that all the stages of treatment are available in Jamaica.
Are available, yes.
That is good news, and I'm sure we're going to be finding out more about that as the program goes through. I want you to tell us though, what is your personal message to Jamaican women at this time?
Well, screen early. I think it's very, very important for you to be in touch with your bodies and to know what your breasts feel like, so that you can sense when something is wrong. Like you, my mother had breast cancer, and she discovered her lump very early. and we were able to do the necessary things. And after having that lump detected, she was with us for another 15 years. So she was able to see my children grow up. You know, I mean, she did suffer at the end. She did have some spread, and that resulted in her demise. But certainly that detection early would have given her a number of years that would have made it valuable to all of us. So screen early, be in tune with your bodies, do your breast self-examination. Our biggest problem is that we're detecting too late. And when we detect too late, more is to be done. The expense is there, the value, not just to what happens in the immediate family, but you know how the family operates in terms of their finances. Everything is affected. But if you screen early, detect early, then you can have a cure.
I love the message, and we will be repeating that message and hoping that others watching share it as well. Thank you, CMO. We really appreciate your being a part of our conversation.
Thank you.
It's Pink Table Talk. Now, when we get back, we're going to dive deeper into this disease, figure out how we can better detect it. Pink Table Talk on TVJ. We'll be right back. National Mammography Day, and joining me on set is a woman who you're going to definitely need on your breast cancer journey. Dr. Daria Cornwell, consultant radiologist, head of the University Hospital of the West Indies Women's Imaging Center. Doc, welcome.
Thank you for having me.
So I know you also teach, so let's treat this as a lesson. You are lecturing, and let's start from the very basics. What is breast cancer?
So, you know, everybody knows the big C, you know, and basically cancer cells are cells that dividing outside of the control of the body. So normally the cells that we have are divide and control, and that's why we come from baby to teenager to adult, and all our cells keep dividing every day. And these cells, the control of the division, the multiplication of these cells is controlled by DNA. And if the DNA that is making these cells becomes changed or mutated to make bad cells, then some of these bad cells could be cancer cells, and these cancer cells can have the ability to invade other organs outside of the organs where they started and cause problems.
And how do we detect it? What are the symptoms of breast cancer? So we've spoken about what cancer is, and I'm going to assume, correct me if I'm wrong, that when that starts in the breast and we're calling it breast, that's when it's breast cancer.
Yes.
Good.
So it's named after the organ that it has started in.
Okay.
Okay?
And what are the symptoms?
Well, you know, I'm going to give you this answer. The earliest sign or symptom of breast cancer is nothing. Normal breast that feels fine, airy, dandy, nice, normal breast. And that is the time that we want to catch the breast cancer while you still feel normal, still feel normal. And breast cancer starts, there's a period of about 2 or so years, 3 years, when it is there taking time and getting root, and the patient has no symptom. That's when we want to catch it. If you don't catch it at that time, then you can start to get lumps, and you get nipple discharge, and the nipple discharge may have blood in it. And especially if the nipple discharge is not from squeezing, when it is spontaneous, you just spontaneously see a discharge on your brassiere, on your towel, or your nightgown. You know, you could have that. Then you could have rash on the nipple. Some cancers start by looking like a rash, an eczema-looking rash on the nipple. We can have an orange scallop look to the orange peel feel to the skin of the breast. You know, we're supposed to have our face looking smooth and nice without any dimples and any holes. And if the skin of the breast starts to look like orange, the green orange with little pores, that is called pouderage. That is one way in which breast cancer could show up. You could also have a redness or a change in the color of the breast skin. There could just be a heaviness in the breast, or even a lump under the arm. So there are many different signs and symptoms of breast cancer, but I want the audience to hear that the earliest sign of breast cancer is nothing, when your breast still feels normal.
And therefore, go get tested.
And therefore
do the self-check.
Yeah, going to come
therefore,
to that. You understand? So it's like being pregnant. When somebody's pregnant, before the belly starts to show, and before they start to get morning sickness and all of that, and cravings, pregnancy tests could show this early in the urine.
Yes.
So that is the time when you want to catch equivalent now of breast cancer. You want to catch it early before it starts to show.
Doc, my mother had breast cancer. Is it hereditary? Should I be extra worried?
Very good question. So about 15% or so of women who get breast cancer actually get it because it's in their family, either through the genetics, the genes, the breast cancer 1, the breast cancer 2 genes, or PALB2 genes. There are many other genes that could predispose a woman to breast cancer very much. And also some women have ovarian cancer and stuff in their family, but 85% of women who get breast cancer are the first to get it in their family. Being a woman, getting older are two of the biggest risk factors for getting breast cancer. Most people who get breast cancer simply get it because it's a woman getting older, full stop.
Therefore, self-check and screen early.
And that is why we want women to hear this now. Once you've reached the appropriate age, I'm sure you're going to come to get screened, start to get screened. Some women are listening to us and saying, boy, I don't have any cancer in my family, you know. It's only old age and sugar and pressure killed my grandmother and my... So I don't listen to them because there's no cancer in my family. But your age is what everybody, and getting older is a blessing.
So age 40 to
age
start.
40 to start screening.
I heard about some BRCG, a gene. What is that? Did I say that right?
You said it very right.
BRCA?
So there's a breast, BR is breast, CA is cancer. That's BRCA gene. So there are 2 genes. There's the breast BRCA1 and the BRCA2. Mutations or changes in these genes in our bodies can increase the risk for getting breast cancer significantly. And women who have this cancer gene in their family, like Angelina Jolie's, right? They don't even have to test themselves. If a woman has family members with this BRCA1 or BRCA2 gene tested positive in their family, that means that that woman's risk of breast cancer is significantly increased in her lifetime. And therefore, she needs to start screening for breast cancer differently to the women who don't have that gene. So that woman now, if she has that gene in her family, will start their mammogram at the age of 30, even 25, 30, is when they start screening for breast cancer, and they add MRI to the package.
So that's when we start to get tested if we have the gene
Yes.
early. But how do we know if we have the gene?
So how we test for the genes is that we do a saliva test. Now the genes in your body, the DNA in your body is in all of your fluid and your solutions, in all of your cells. So we simply can do that, and this is done in Jamaica, where we can test the saliva for the genes, the gene, and if it is present, then we know that there's an increased risk factor. So what we advise women is this. All women who are listening to me, once you've reached the age of 30, all 30-year-olds should go to their doctor and have a discussion. What is my risk profile? The doctors know the different things to look at to see if it is that they are increased risk. And when the doctor then say, okay, your risk profile is such, you may not have the BRCA1 or the BRCA2 genes, but family history of things like ovarian cancer and stuff, and breast cancer can increase the risk even outside of having the gene positivity. And if that is so, then the woman would have to start her screening as early as 25, 30.
So if we start early, depending on the conversation with the doctor, and even if we didn't start early, definitely at 40 we're doing the mammogram. But where are you in the picture? At what stage do people come to you?
Okay, so I'm a radiologist, right? And the radiologists are the imaging experts. So we are the ones who we interpret the mammogram. And a mammogram is an X-ray of the breast that is done to pick up cancer. And so we are at all radiology centers. We are the ones who pick up the cancer, right, early. I'm at University Hospital, I'm at Precision Imaging Center. So there you can come, and there are other radiology centers that you can go to throughout the world. I know the world is listening to us. So we're encouraging women, when you've reached the age of 30, if you have an increased risk, and 40, you go to any radiology center that offers mammogram and get your mammogram done. That's an X-ray of the breast that picks up the cancer. It can pick up the lumps and cancers 2 years to 3 years before the lumps can be felt.
So we're talking about having breast cancer before there are any lumps and that early stage there, but what are the stages of breast cancer?
Okay, so we have 4 stages. We have the early stage, we have stage 1, stage 2, stage 3. As the number goes up, the stage increases, and the stage of breast cancer has to do with whether it's confined to the breast or whether it has moved locally to an area close to the breast or beyond. So if it is stage 1, 2, this is where it's confined to the breast, and the size of the lesion determines the stage in that case. When it has spread now to the nodes, so breast cancer can spread via the bloodstream or via the lymph nodes, and it can go to the lymph nodes under the arm. And if that has spread to the lymph nodes under the arm, it would be stage 3. And if it has spread beyond that to like the lungs and the brain and the liver and the bones, then it is stage 4. So that's distant metastases. So the stage depends on the size of the tumor that is found within the breast, and if it's spread outside of the breast now, to how far it has spread. If it is to the axilla, it's a local regional, it's stage 3, and if it's beyond that, it's stage 4. So you want to catch it early.
Taking us right back to where we started with testing early before you even feel anything.
Because even at that stage, before you feel anything, something is still happening. And it is not all cancers that give us the opportunity to pick it up at an early stage. Some cancers we don't get that, so screening is only you only screen for cancers that you know you can catch them early and make a big change in the outcome and give a possible chance of a cure. And breast cancer is one of those cancers that we could find it before it reached the size to be felt or anything like that.
I've got it, Doc. We understand. But we will continue to repeat that message.
Yes.
And, well, of course, when we have to do the checks, we'll find you, University Hospital of the West Indies or at Precision
Yes.
Imaging. Ladies, so much valuable information. Please do your own self-test, your test, and then get a mammogram done when you are at that age of 40. Thank you, Dr. Cornwall.
You're welcome.
Up next, we hear the stories of our two breast cancer survivors, Misha Ruddock and Carolyn Graham. Welcome back to Pink Table Talk, our discussion program on breast cancer awareness. And we have two strong, powerful women on set. We heard a bit of their story earlier, but in this segment, we get to dive in deeper. So welcome, ladies. Glad that you are here and thriving, and I'd like to encourage those who are watching us online that you can send in your stories and ask your questions on TVJ's Instagram account, hashtag Pink Table Talk TVJ. So, Mesha, let's start with you. How old were you when you found out?
So I was only 28 years old.
That's even before the early screening age. How did you find out?
I actually felt a lump. So I describe it now as a hardening. I didn't know really what a lump was. So in doing my own self-checks, looking in the mirror, touching, feeling, being in tune with my body, I felt the difference in the left breast area, and I was encouraged to go and check it out, and I did just that.
You're saying it like it was nothing, but when you found that, how did you feel?
I mean, at the time, I wasn't overly concerned, to be very honest, because when I first felt it, I was like, lumpy breast, I've heard of lumpy breasts. Maybe it's nothing to be too concerned about, because the truth is I do not have any form of cancer in my family. So cancer did not come to mind in the beginning at all. So I went and I got it checked by my doctor, my general practitioner, and he was also concerned. So we started to take the additional steps.
And what were those steps? Walk us through the treatment.
Those looked like, I know I describe it as a whirlwind, because when he said, he too is concerned with what he's seeing, he said, let's do an ultrasound. And when I went to do the ultrasound, on an ultrasound, you can identify whether this is a cyst, which is more like a fluid-filled sac. By the way, I got a medical degree along this journey. Or if it looks more like a mass, something that is of concern. And following the ultrasound, there were concerns. It looked as though it was having its own life, which means it's connected to blood vessels, and that's what they describe as a mass.
And you thought when you heard that?
I started to cry. I mean, the worry set in at that point. I do live with a positive outlook on life, though, because I know a mass doesn't always have to be malignant, cancerous. So I was still hopeful that it was nothing. I was still in my this is nothing era and phase.
And you found out that it was something.
I did. And this is after I was encouraged to do a biopsy or a breast MRI, but I opted to do the biopsy, which, they take a little sample out of the area and test it. And I waited about 6 weeks for the results to come back, finding out that I was diagnosed with stage 1 invasive ductal carcinoma.
The 6 weeks alone.
Trust me, anxiety filled. Wow. Anxiety filled.
And when you heard now the confirmation, what were you thinking?
I had no thoughts. I remember feeling as though the earth had opened up beneath me. I believe I immediately had an anxiety attack. But my doctor did his best to calm me and positively reassure me that we caught it early. It is stage 1, and this is the direction. He started to chart the path for me around my care.
And here we are, how much longer?
Well, last week Saturday marked 4 years post the double mastectomy. So yeah, living, thriving, giving thanks.
After taking off both breasts, to be sure.
Well, I had to take off 2 because I was actually diagnosed with bilateral breast cancer, which is very rare. So oftentimes women find breast cancer in their left breast. The left breast is very frequent, but the right can also be. When I was screening to prepare for surgery, I found out that it was also in my right breast. So here I am, the anomaly, no evidence of cancer in my family, 28 years old, diagnosed with bilateral breast cancer.
How did you manage after taking off both breasts mentally? What was that?
That still is tough, I should say. I mean, safe and aside from the physical turmoil your body endure and is trying to heal from post-surgery, it has been a psychological and physical struggle, getting to know the new me physically. But I'm still grateful that I have life. I get to advocate and encourage women that, you are not your breasts. So there is more to life than this disease.
And there is support for you in this process right here in Jamaica.
Right here.
What has that support been?
Luckily, I'm a member. I mean, you kind of have to have gone through this journey.
It's on your shirt.
Yeah,
Reach
to
to
be
Recovery
a member,
Jamaica.
and I'm a proud member. I'm happy that we have a safe space to provide support to men and women who have been diagnosed with this disease and are going through their own journey.
You've mentioned Reach to Recovery. You've brought us here, and it's a perfect time to move to Carolyn, who was president, is it Carolyn, of Reach to Recovery for many years.
Yes.
Welcome. When you got your diagnosis from your doctor, what was that like for you?
Well, I can truly say that I think a diagnosis, when you hear a diagnosis of breast cancer, it affects your hearing, because I went deaf. I heard nothing further. I saw his mouth moving, and I knew he was speaking, but I heard absolutely nothing.
Your stage was different. You weren't in your 20s.
No.
So at that time, you must have had a pretty good feeling of what was in your family and what the things were that you would possibly be at risk of. How was that for you?
Well, in my family, my father had prostate cancer, but that's as far as I'm aware of cancer in the family. I was menopausal, and my doctor was Dr. Thwaites. And he suggested that I do mammograms with regularity because I had reached the mature stage of menopause. And I did my mammogram every year. And 21 years ago, I did a mammogram, and it came back with little specks of what looked like sand. And he called me in and he said, you know, we have this report and I don't like it. And I said, of course, I was very sure here, there was an error in the screening. They had a dirty slide. So I'll do it again. So off I went, did it again. And can you believe the same thing happened the second time? So he called me back and he said, it's happened again. Now can you come in and see me? So I went in and he said, you know, we need to go further. We need to do a needle biopsy to see what these little grains are. So I did my needle biopsy. And then he called me back and he said, you need to come in and see me. Now, at that stage, you start getting a little antsy because you did this test and your doctor is now telling you he wants to see you. So I went and he sat me down, and this is when he told me the results have come back and you have breast cancer. I went deaf. I eventually left him, went to my husband's office. Of course, poor soul, he didn't know anything that was going on because I didn't take this thing seriously. I thought it was nothing happening. Sat down in front of him and wept. I think he must have wondered if, you know, what was going on here. I explained to him what was happening, and we decided, you know what, we will fight this. Together, we will get through this. So we then made an appointment with the doctor again, went back, sat down with him, and I heard, this time my hearing
You were
worked.
listening this time. Okay.
And he suggested that what should be done, you know.
What were the stages of your treatment?
Well, mine was really very simple. Mine was stage 1, and it was estrogen positive. So what we did was we said, okay, there are little grains of sand, so there's nothing to take out. You can't do removal of a section, so we would remove the breast. And we would go on hormone suppressant drugs for 5 years. And that was the extent of my treatment. Surgery, 2 days from now will be 21 years anniversary of my surgery, 19th of October 2004, sorry. And here I am, thriving.
And is there any further concern?
The truth is, once you have had a diagnosis of cancer, anything on you that seems a little odd, your mind immediately goes, could it be? And I think that's probably true for all of us. There's this constant
Fair.
fear.
Somewhat.
Could it be?
So here we are, two separate stages of life, two separate experiences or different kinds of experiences. And there are women watching now who are menopausal and probably thinking that they are past. What is the message from you?
The message from me is menopausal women are more likely to encounter breast cancer because of the aging process. But it has happened to girls in school. So age is not it's a factor, yes, but all women with breasts should be conscious of how your breasts feel. And let me add here, men also have breasts. I mean, when you tell a man he should make sure he checks his chest, he sort of says, but I don't have breasts. They do have breasts. They have breast tissue. So men also should be careful of what is happening with their chests. We need to get familiar with our bodies, know how they feel under normal conditions, so that if there's a change, you feel it.
And I'm sure, Mesha, that you are echoing the
100%.
sentiments here.
I would also encourage ignore nothing. Ignore nothing. Get in tune with your body. The moment you feel a change, sense a change, check it out. It's very important.
Thank you for being so frank, so open, ladies. These have been amazing stories, and I'm sure that you who are watching now may have questions, maybe some comments for our survivors, support, and for the doctors that we've had on the show so far. you've been afraid to ask or not quite sure how to ask, or maybe you just want to send some love and strength to somebody that you know that has this disease, use the hashtag Pink Table Talk TVJ so we can find you and send them all on TVJ's Instagram page. Now, Dr. Gillian Wharf is a consultant hematologist and oncologist at the University Hospital of the West Indies, and she's joined our panel to assist with helping us to figure out the whole process of detection, or processes of detection and treatment and everything in between. Dr. Wharf, welcome.
Thank you very much for having me.
Let's start with your titles and what they relate to, or how they relate to breast
All right.
cancer.
So I'm professor of hematology and oncology.
What's a hematology?
So hematology is disorders of the blood, and they can be non-cancerous or they can be cancerous. So the non-cancerous ones would be things like iron deficiency, B12 deficiency, that kind of thing. The cancerous or malignant ones would include things like lymphoma, multiple myeloma, and various other blood disorders. The leukemias also fall under our portfolio. And the oncologist part is usually the solid tumors. So we're talking then about the breast cancer, the colon cancer, the endometrial cancer, all of those cancers. So our department looks after all of those patients, and I am one of the staff members there.
When does a woman come to you, the oncologist?
Interestingly, in a variety of situations, some of them will come to me because they're concerned about something, and they come to me first. But most of the times they come to me after a referral from another practitioner. So the referral may come from one of the family physicians. More commonly, we see patients after the surgeon has seen them, and they send them to us. So these patients would come to us not necessarily having had an intervention, but having a concern, maybe a biopsy, and then they would come to us to determine where we fall in the line of treatment.
And how do you work with the other doctors? So you mentioned sometimes it's after the surgeon, after surgery that they're
Sure.
sent to you. Sometimes it's before.
Right.
What is your communication with the doctors?
Certainly. So let's start with a patient. Maybe a patient felt a lump, or they fortunately had screening done and something abnormal was found. The next step would be to do a biopsy, and very often our interventional radiologists would do that biopsy. That is the best biopsy. For sticking to breast cancer, they would do that biopsy because you get a much better quality sample than just excising the lump.
Which is?
It's where you cut out the entire lump that you can feel, right? So the interventional radiologist would use a special needle and take multiple pieces of that tissue that looks abnormal and send it to the pathologist. The pathologist says, okay, this is malignant. There's another step in between where we have to determine what are the drugs that are most likely to assist in this patient's care. So this is what we call immunohistochemistry.
Wow.
So that's a special test that says, is this cancer driven by hormones, or is it driven by something else, or that you know, everything is negative, and therefore this is one of these what we call triple negative breast cancers. So the pathologist gives us that report. The surgeon then sees the patient, and the surgeon then says, okay, you need to go to the oncologist first, and that oncologist then determines a plan of treatment for the patient. And when the drug part of the treatment is finished, then we send the patient back to the surgeon for more definitive management of the abnormality in the breast.
All right, hold on.
It's a lot.
It is a lot.
It is a lot.
We can't dive too deep, but if I'm understanding it, there are different types of breast cancers.
Absolutely.
So you have to help figure out what is the type of breast cancer and what the best treatment is.
Correct.
Which also includes the surgeon. Do
Correct.
they always include the surgeon?
Yes.
Because you have to take a dose.
Yes.
But before that, you may need to
We
be
may need
prescribing
to.
drugs.
Correct.
Or what
Yes.
else would you do prior to or
So we do staging. So that determines, is the cancer limited to the breast and maybe the lymph nodes? We need to make sure that it's not involving the lungs or the liver or the bone, because in that case, the cancer is no longer curable, certainly treatable, but not curable. So we have to determine what that is at that point, so that we can, advise the patient the best route for their management.
And the options include drugs.
So it would be
chemotherapy.
correct. Yeah. And we have the biologics. So now we are using things like immunotherapy for certain kinds of breast cancer. We're using things like the anti-HER2 medications, because some are driven by this gene, the HER2 gene, which is overexpressed in about 20 to 25% of breast cancers. And so these patients, they have a target that we can use a drug that targets the abnormality to have a better outcome for these patients, rather than just blanketly treating everybody with chemotherapy.
Wow. You are proof why we need help in terms of understanding the gamut of things that come up with breast cancer that are involved. And I know we have questions online. Our social media audience members have been sending in questions. So let's see if we can take a look at the first one. Can birth control cause cancer? And of course, particularly breast cancer.
Right. So when we're taking a history from a breast cancer patient, we do talk to them about whether they took oral contraceptives or hormone replacement.
Wow.
Because it can increase the risk of breast cancer. So we just want to document what are this patient's risk factors. It doesn't mean that we should be telling patients don't take oral contraceptives. And certainly if you have a lot of postmenopausal symptoms and you need to get hormone replacement therapy, the recommendation is to treat patients who have a symptom, not because patients just want to feel nice, that hormones are still there. If they have a symptom like a lot of hot flashes and so on, and they're not responding to the other medications, those are the persons that we would want to offer hormone replacement, and it's time limited.
Got you.
Yeah.
We have another question. This one says, if I have breast cancer, how quickly can it grow and what kind of costs are involved in the treatment?
Sure. So the rate at which a cancer grows, again, depends on this kind of immunohistochemistry thing that we need to know. So the hormone receptor positive cancers, meaning the ones that are driven by hormones, they tend to be slower growing than the ones that are triple negative or the ones that are HER2 positive. So the ones that don't express hormones or HER2, those are very aggressive cancers. And those are the cancers that may turn up in between screening. So you recommend screening every year for patients, but some people may have what we call these interval cancers, particularly those are usually more aggressive cancers. So they appear under the 1 year period that you want to ask patients to have screening.
And the cost, the second part of that question was, just a general idea from our range.
Okay, so the cost varies. So the hormonal therapies are covered or supported by the National Health Fund. So certainly for patients in the public systems, those patients don't pay for these drugs at all.
Wow.
At the University Hospital, we're not really considered public, and so they pay a discounted price. Other drugs, like some of the chemotherapy drugs, are also on the National Health Fund. One that we use a lot, a drug called paclitaxel that people would talk about and have to get it every week and that sort of thing. That is also covered on the National Health Fund, so that reduces the cost significantly.
So you're saying if we go through the public health system, it can be affordable?
But you can also, they don't pay anything. But for those patients, even private patients, they will get a discounted price. And the big one is the anti-HER2 drugs. Anti-HER2 drugs can run you $300,000 a dose. But in the early stage breast cancer, the National Health Fund supports that drug free of cost for the entire year that the patient requires this treatment. So this treatment is given every 3 weeks for a year, so 18 doses. So you know that's a significant cost impact. But for the hospital systems, the University Hospital, Kingston Public Hospital, Cornwall Regional Hospital, those patients are actually getting that drug free of cost for the full year.
That
So
is fantastic
that is
news,
absolutely
Doc.
wonderful and helpful for the patients.
So there is hope, because one of the big fears I know with persons who are contemplating cancer is that they will not be able to afford.
Correct.
But
Yeah.
that is
Yeah,
fantastic
it
news.
is
Thank
very,
you.
very good. Very, very good.
Lots of news, lots of information, lots of good news, and the promise, the hope that there is life beyond the diagnosis. Doc, thank you so much for joining us.
Thank you for having me.
Thank you for joining us online. Keep your questions and comments coming as our program continues. Ladies, no matter what, get tested, especially if you're at risk, and get tested early. Start your tests early. Up next, we discuss recovery, dealing with the new reality. Pink Table Talk will be right back. You are back with us on Pink Table Talk. Now, after a diagnosis of breast cancer and even surgery to possibly remove a part of the breast, a whole breast, both breasts, we as women naturally are emotional. There's a lot going on. So how do we deal with it and what are our options at that point? Joining me on set now are our plastic surgeon, Dr. Rajiv Venugopal.
That's right.
And we also have clinical psychologist, Dr. Carol Powell Booth. Dr. Powell Booth, we're going to start with you. And I think my first question is, from the perspective of a doctor, what does counseling a breast cancer patient look like? What are the stages when I come to you?
Well, believe it or not, because we are humans first, we too go through quite a bit of emotions with our patients. At first, we have to communicate with them that we empathize with them. We have to make them as comfortable as possible. And each person is at a different stage in terms of their own recovery. Some persons are still at the stage where they're in total denial and shock. Others may have gotten a little further along the way. But what is most important, first and foremost, is for us to make them as comfortable as possible. And then after that, we work through with them the different steps in terms of perhaps just accepting that, you know, they have this diagnosis, to work through with them whether or not they have the adequate support that they need, and to help them through each stage in terms of the recovery.
I didn't even think psychologist. I'm thinking breast cancer, medical doctor to look at, take out, etc. At what stage do you come in?
It varies. Oftentimes, though, we come in sometimes after if there is any kind of surgical procedures or any other kinds of intervention medically, we most times come in afterwards, because the most important thing at the top of person's priority list will be to deal with the diagnosis from a medical perspective. So oftentimes as a psychologist, we come in much later along the journey in terms of, you know, providing the emotional support, etc., the clinical intervention that is needed.
And how challenging is it for you, breasts, how we think of our breasts as us in many
Yes.
cases? How challenging is it for you when dealing with a breast cancer patient versus another type of patient?
Well, it's particularly challenging because, as you mentioned, Paula, you know, a breast is not simply considered to be even like a foot or a finger. It's an essential part of who we are as women, as females. And so it can be challenging, and that's why we sometimes have to get our own emotional support from our own therapists, interestingly, so that we can be at our optimal to provide the necessary support.
Hold on, you're saying you as a psychologist, you have to have a psychologist on call.
Oh, yes. Yes, because it can be very emotionally demanding for us to be at our optimal in order to give our patients all that they need. And so it is recommended from we are in school that we also need to get our own support as well.
And you've mentioned, I'm going back a bit, but you mentioned that you may come in at different stages, but usually it's after clinical treatment. Isn't there a need before?
There is. There actually is. But again, because persons don't usually think psychologists in the early phases, but we actually, it's useful if we can be there from the, you know, shortly after you get that diagnosis, that you could come in for counseling, because as one of your previous guests mentioned, many times persons go into shock and their mind goes numb and they're not sure what are the next steps, because inevitably persons might consider, I've gotten a diagnosis of breast cancer, I'm going to die. That's not necessarily the case, but then sometimes because of that they get depressed, they may become, you know, they may have feelings of panic, you know, just not knowing, confusion, not knowing what should be the next step.
Dr. Venugopal is here. Do you often work closely with psychologists, with the plastic surgeons?
We work with, as a team, with many other clinicians, yes.
Okay. And so we jump across to you, Dr. Venugopal. Thank you for coming.
Thank you.
Help us with not the taking out, but the building back, the putting back, the reconstructive surgery.
Right.
What
So
exactly does that entail?
I think I'm going to just touch back. I think the emphasis is that there's a large team taking care of all of these patients, and every single person on this team is important. I think the other thing which you said, which I'm going to emphasize, is that, you know, the breast is probably the most obvious external feature that separates a man from a woman. You know, it symbolizes, you know, her femininity, her maternity, and sexuality as well. So it's a huge impact on just the day-to-day functioning of a person. So the role of reconstruction is to try to build back that confidence, and hopefully the aesthetic outcome of the reconstruction will also be satisfactory to her.
So we're hoping it looks good as well.
Right. So the reconstruction can be broadly described as being two roles, using your own tissue or using prosthetics, otherwise known as implants. You know, both the paths are individualized, so it requires, you know, multiple meetings with the patient and discussions with the other members of the team to make sure that the coordination of the oncology or the cancer treatment is not affected. So what I always say is that our treatment is important, but not as essential as the taking out, as you said. But we are there to see them early as well. Just like you emphasized, the psychologist should also be early. Now, each person will have a view on how much surgery they want to do, how much scar they're willing, how much downtime they can accept, and all of those things have to be put into the mix to decide which path one takes.
Can you, in summary for us, tell us again the different types and the downtime for each?
Well, using your own tissue is, you know,
that's
basically
autologous.
Autologous, right. Auto means in medicine your own. So we're basically taking fat, and the most common area, it would be your tummy. You know, stuff that we would have thrown away on a tummy tuck is kind of transferred up to the chest wall. It's a bigger operation, but the recovery from that can be, you know, up to 3 months, but there's ongoing recovery for maybe 9 months to a year. So that, but the advantage of that operation is that you do that one big operation, you may not need multiple other operations.
And you can take from the tummy and where else?
Well, you can go to the back, but the back fat is much smaller, so the cup size that you can create is smaller. So it, you know, it's not the number one site.
All right, we got that. What are the other
So the other method is using the implants, and generally they can be put in at the same time. So both these procedures can be done immediately at the same time, and there are advantages psychologically. You know, the patient feels that the procedure has started in terms of reconstruction. It does have, you know, recovery time because you're blending the two, and that also translates into, you know, the overall times you're going to visit the hospital. Prosthetics usually require multiple operations, but no new scars, shorter recovery. But these things have a shelf life of roughly 10 years. So
and they're different kinds?
Right. They can be filled with saline, salt water, or silicone, what they call gummy bear. Right? So
and the shelf life is about the same for both?
The same for both. It's just my personal view is a safety profile. You know, saline, 80% of our body is saline. You know, the gummy bear is supposed to feel a little bit more natural. So again, that's another counseling process with the patient. And
how does the downtime compare to using your
autologous? Right. So, you know, you probably be back in 6 to 8 weeks using implants as opposed to the 3 months. So definitely a big change in the downtime.
Which is more expensive, Doc?
That's a good question. Immediately, the autologous, because theoretically it is a lot more technical. If you measure it over a period of one's lifetime, the prosthetic is, because you're going to have to replace the prosthetic multiple times.
And how is funding work for the reconstruction surgery? So we heard there's funding for treatment available in Jamaica. How about for the reconstruction?
So what I'm proud to say is that, in Montego Bay and in Kingston, all the public hospitals have plastic surgeons who can perform this. So it is within the access for most patients.
Okay. Whew. Benefits, very quickly as we wrap up, because we're thinking about it, we're thinking about spending the money. We know it's available.
Right.
Should I or shouldn't I?
And again, it's a very personal decision. Doing it immediately versus just getting rid of the cancer, getting all that treatment done, and then doing it delayed when maybe you're more mentally and physically safer. So it really is a very personal decision.
Thank you so much.
And thank you.
Doctors. We actually did a little research. No, not on the choices for reconstruction, but we found a tattoo artist working in the States who uses her skills to cover up scars as well as create areolas. We caught up with her via Zoom.
Most of our breast cancer survivors who have had surgery to remove the breasts, they're left without areolas because the areola is also removed. So they come in and they want to get the area enhanced. They want to kind of feel more like themselves, and I help them do that. It is a little bit different because of the fact that you're tattooing most times on a scarred area, because the incision kind of runs right along where your nipple does fall. I mean, it varies from person to person, but I would say maybe about 80% of persons, their scar falls right along where the areola would have been. So in terms of the actual execution of it, you do have to be familiar with working on scarred skin, which I was already familiar with because I do cover up tattoos a lot, actually. Most of a large percentage of my clientele, they come to me for cover up tattoos. It's actually one of my favorite specialties. So it was kind of easy to move from that and dive into the areolar tattoos. Okay, so I'm going to keep it real, all right? It does hurt. However, specifically for my areolar clients, I provide numbing. And because the service itself, like the actual tattooing part of it, it takes about 2 hours. The numbing cream lasts for the entire 2 hours. For the most part, the numbing cream I use, it lasts for about 4 hours. So we're able to execute both both areolas almost painlessly. There are some people though, so let me put this, there are certain people though, like depending on the scar and depending on the person, it's one of two things. It's either the area is more sensitive or not sensitive at all, right? It varies from person to person, especially with how it healed, right? But for the persons who are sensitive, what I have found is that there might be like a twinge of discomfort, but nothing excruciating once we use a numbing, right? Outside of the numbing cream, yes, I would say it is just as painful as a normal tattoo, with the exception of persons who their scarred area is sensitive. I recommend that you wait at least a year after your surgery before you decide to get areola tattoos. And the reason for this is you want the area to be fully healed. You want to sign off with your surgeon to ensure that, yes, you can go ahead and tattoo this area. They won't need to go back in. You want to ensure your doctor passes it. So I would say give yourself a year to fully heal. Give yourself a year for your doctors to pass you.
Options everywhere. I want to come back to you, Dr. Venugopal. she mentioned tattooing around the nipple area, but you also offer nipple reconstruction. How does that work?
Right. So what you just heard is the concept of 3D nipple tattooing, where they use their artistic ability to try to create on a flat surface an image that is projecting. In terms of our nipple reconstruction, we're utilizing the same tissue which we may have brought up to actually create a projection. But we also do need to create the areola, which is the dark area. So we actually may go and get a skin graft from another area which is darker, usually in the lower part of the body, and the scar can be hidden, and then create the areola that way.
So you create an areola and you actually create a nipple that protrudes like
Yes.
like the original.
But what we've learned is in certain situations, it is safe to preserve the nipple. So the overall aesthetic outcome when we preserve the nipple in the mastectomy process is much superior to what we can create. Because the projection that is maintained with the natural nipple is lost over time when we actually do the reconstruction.
Hence the importance of working as a team
Yes.
with all of the other doctors. Wow, so much to consider. We are very blessed to have you both with us to share this information. Thank you.
Well, thank you.
Thank you,
Thank
thank
you for
you.
having
And
us.
our stories are still not finished. Up next, we have survivor and managing director of Reach to Recovery, Sandra Samuels. She's going to join welcome back to Pink Table Talk. It's our closing segment, and I really hope we've been able to provide you with enough information and push you to get tested. And remember, you start with the self-examination. That's a first test. Sandra Samuels, president of Reach to Recovery, is here with us, as well as Ashley Arbery from Bahamas Air, one of our sponsors. We're starting with Sandra. For those who don't know Sandra, what is Reach to Recovery?
So Reach to Recovery is a group of breast cancer survivors. We have been around since 1982. We were founded by Dr. Denise Thwaites, and she herself was a breast cancer survivor. And so from 1982 to 2000, what we did mostly was counseling. And so in 2000, we came to a decision that most of the persons that came in for counseling really needed funds. So we had to embark on a fundraiser. And what better to, do a fundraiser on a healthy lifestyle, start a run. And so we started a run. We had like about 700 people at the time. And then so fast forward, we are celebrating our 25th anniversary this year. Last year, with the help of our sponsors, we were able to raise $19 million. And this year we are aiming for $25 million. And at Reach to Recovery, this money goes to well-needed women when they are diagnosed with breast cancer and they have nowhere to turn to start the treatment. That is where we come in. So at Reach to Recovery, we give each person, or should I say, we afford each woman up to $150,000. That might sound like a little bit of money, a lot of money to some people, but it's really a drip in the bucket. These funds now really just starts the process. So if you need to do a mammogram, an ultrasound, a needle biopsy, a bone scan, CT scan, anything of that nature, if you want to pay for medication, if you want to put the money towards your surgery, we don't give you the cash. We pay whoever it is, whether it's the doctor, the pharmacy, the place that you're going to get the scan done, the place that you're going to get the mammogram done. And I mean, yes, persons could possibly go to only two places offer public mammograms, which is Cornwall Regional and KPH, but the wait is long. So we pay to get it done privately, or we send it to, still not free, we send it to Jamaica Cancer Society.
Now, Sandra, you've mentioned the funds, which are very important, especially for people who don't know where the first dollar is coming from. I know my mother has been, was it 26 years now?
She and I came in at the same time.
She's a survivor.
Yes.
And you cannot say anything wrong about Reach to Recovery for her. She lived through that support. And she now is a part with you, providing that experience for other persons. So what is your journey, Sandra?
So in 1999, and that's why I'm a member, because in 1999 when I was diagnosed, Mr. Gurney Beckford, God rest his soul, he introduced me to Donna Carroll, who was a member at the time. And when she came and she counseled me, she was at the time surviving 15 years. And what that did for me, it gave me hope. And so speaking to her, she telling me her journey, I see her surviving. It's all well and good when your friend or your family who love you come and tell you that everything's going to be all right. But when someone comes who has been through the fire, who has been there, done that, can tell you what to expect and what you need to do, it's a world of difference. Your mindset shifts and you get into a very hopeful zone. And so when I went to the meeting, it was a whole slew of women surviving 20 years, 25 years. I was amazed because at the time, back in the day, 26 years ago, breast cancer wasn't being spoken about like how it's spoken about now. So it is for us. We meet every second Tuesday of the month at Webster's Memorial at 5 o'clock, and we support each other. We welcome new members, not because we want to welcome you to the fraternity, but at least you know that there's a space where you can speak about breast cancer freely, and the next person that you're speaking to totally understands what you're talking about. You know, your fears, your anxiety, you know, all of these things. So, you know, Reach to Recovery is more than just a support group, it's a sisterhood. No, we started 3 years now, we started, you know, doing, you know, a yearly, you know, retreat, because we understand that surviving breast cancer, I would call it 80% of it is mental. So you need to be fortified mentally. So it's not just about talking about breast cancer all the time. It's about living a quality of life. And speaking of quality of life, at Reach to Recovery, we also provide, you just spoke to Dr. Vanugopal. He does reconstruction. Now, not everybody can afford reconstruction, and for myself, I couldn't do reconstruction because I had done radiotherapy on the area where I removed my breast. And so at Reach to Recovery, we provide prosthesis, specialized bras, gym wear because we're still active, swimwear, and we also have the swim form.
Lots of support.
Yes.
When I come back, I'm going to share a question from someone on social media, on Instagram, and when we come back, I want you to quickly tell us how the rest of us can help. So the question is, how has going through the cancer journey impacted your relationships?
You mean in terms of male relationships?
All of them.
Well, I must say, when I was diagnosed at 35, my main concern was my loving relationships, of course, my intimate relationships. You know, when somebody tells you that they like you, at what point do you tell them that you only have one breast? That was my main concern. I never thought about dying. That was not in it for me, because I'm an eternal optimist. So I had to find a way to say, okay, well, in speaking to other people, you know, they said to me, look, it's an opportunity to weed out the riffraff. If they don't want to be with you, to go through with you through your journey, or to be with you,
They're not worth it.
it's not worth it.
So at what point do you say?
So right now, because I'm still single, right now, and that's my choice, by the way, the minute you express interest, I say to you, this is my situation. Because I don't want to go into the rejection mode when, you know, I lead you along the road and you fall in love and then all of a sudden I say, you know, say it's one breast I have. No, we're not going there. And so the conversation has to be had early in the day.
You know
so you can make a choice, because we're as adults, we make choices. And if you can't manage it, you can't manage it. No problem.
What I love is the strength, the confidence with which you just speak it. It's your reality, and it's what it is, and you
it is my new norm.
Take it and deal with it.
Yes.
And you, in the expression of your story and the support from Reach to Recovery, give other women who are not yet there the strength to live it in a similar
Reaching
way.
hearts, restoring hope. That's our motto this year.
So what you want from the rest of us now?
Well, outside of your support, we want not to be welcoming many women at late-stage breast cancer. We want, that's why we are spending the time to spread the word. We want you to get tested. Go out, first of all, test yourself, check yourself every month, same time, not during your period, 5 days after your period, so that if there are any changes in your breast or in your chest area, you will notice, because that's what saved my life. Because my lump or hump, I would call it, was in my chest wall. I did a mammogram, and my mammogram came back negative.
In your chest?
It was in my chest wall in the 12 o'clock position. So if I was unaware of my body, because I had taken out a lump 9 years prior, so if I was unaware of my body, I would have missed it. And so I had put on my clothes and I was going through the door, and the doctor said to me, but you don't look, you know, happy with my decision. So I said no, because I'm sure that hump was not there before. And so he followed up, and I recommend you follow up with an ultrasound. And then what he did after that now was to follow up with a needle biopsy that proved that it was indeed breast cancer.
Sandra, you know what I'm hearing directly and differently here. Not just self-test, but test often enough so that you are familiar with the feel so that you know the area.
The changes, you know the changes.
Know the changes, and that
Absolutely.
won't happen
And
if we are
you
arbitrary.
need to feel underneath your arm, in your neck area, because nobody gets, tells you about, okay, you may have standing nodes, which I found out at my time of diagnosis, because the lump was very much there underneath my armpit, but nobody had told me to check
That's
underneath
a part
my
of
armpit
it.
as a part of it.
Thank you so much for that. And thank you for letting us know the ways that we can support. And one of those ways is through sponsorship of the program with Reach, just the entire effort. And one of our sponsors for Pink Table Talk is Bahamas Air. Welcome, welcome, welcome. Why is Bahamas Air sponsoring a part of this whole breast cancer awareness effort?
Well, a great way to start the answer to that question is by saying Bahamas Air is the national flag carrier of the Bahamas. This means we carry a great responsibility to connect the Bahamas with the wider world and the wider world with the Bahamas. And we do more than just flights. We don't want to just get you safely and reliably to your destination. We care about you and your well-being. So that's why we're here today.
Oh, wow. And how have you been supporting outside of working with Pink Table Talk?
Yes, so of course we travel to several destinations. On each one, we take pride in going beyond just being a flag carrier. So we're thinking pink and flying pink all month long, and beyond just October, every day of the year, we transport patients and healthcare providers and getting them to and from places for them to be screened or even have healthcare provided.
How about in the workplace with Bahamas Air, Ashley?
Yes.
Is that something that you are executing as well?
Most definitely. So it starts within. So of course we even have employees who have battled breast cancer, right? So all month long we've had several seminars within our establishment, our different offices. We have banners and flyers about awareness, because we want to just talk about early detection, of course, and then how do we go from early detection to now action beyond that.
And you are helping to make that action happen
Yes,
with this
yes,
awareness, Ashley.
yes.
Thank you so much. Sandra, it was a pleasure listening, learning, and sharing with you. We are so happy that you were always also able to join us on Pink Table Talk. That's it for our program today. I believe it was a lively discussion. It was filled with just so much information. At the end of it, though, we're only encouraging you to test yourself and go get tested, no matter the age. It could save your life. So thanks to all of our sponsors. Lucozade was in there, KFC, Precision Imaging, Pioneer Manufacturing, Bahamas Air, of course, the Ministry of Health and Wellness, and our gift partner, National